Hi, families. Thank you for coming to our virtual parent caregiver group that we hold every month. This month, for the month of March, we have our very own Katie. Katie Austin is our occupational therapist here at Collaborative ABA Services. Katie's going to talk more about what is OT and also how you can help support your child across different settings. So, Katie, I'm going to hand it over to you.
Awesome. Thank you. All right. So, all right. So when I have my screen up, I cannot see you guys, but can you guys see the presentation?
Yes.
Perfect. Okay. So if you guys have any questions, please feel free to type them into the chat. But I'm just going to kind of get going. So, like Alicia mentioned, this is a presentation about what OT is. And different ways that we can help support children in occupational therapy and kind of just give you guys a little bit more information about it. Um, So, just a little about me. I've been an OT for the past 12 years. I specialize in pediatrics. I have a couple different certifications in specific trainings and protocols and programs that are specific to kids. But I've been working with ages birth to 12 and outpatient and home based settings for my career. I love working with kids, it's something I really enjoy, and I'm really passionate about it. So, what is occupational therapy? So, I always like to start these things with just straight up Googling what is occupational therapy just to see what comes up. And when I Googled it, it said a form of therapy for those recuperating from physical or mental illness that encourages rehab through the performance of activities. So, that I think is a great description of what occupational therapy is for adults. So, if you get into a car accident or if you have a serious injury or something happens and you need to recuperate or regroup from that illness or that injury, OT can absolutely help you with getting back to doing the things that you need to do, getting back to work, getting back to, if you have, say, like you break your leg, how to dress myself, how to figure those things out. But in pediatrics, similar to the difference between adults and kids, pediatric OT is very different. So AOTA is the American Occupational Therapy Association. And so if you ask what occupational therapy is, their definition, I think, is a better description. So I highlighted the most important parts. OTs use everyday activities to improve well-being and improve participation in things that are important to the person. So meaningful activity, everyday activities, and promoting participation. So those are the biggest things I think about when they say, well, what is OT? How do you help kids? I do activities that are meaningful and fun and engaging for them to increase their ability to do the things that they need to do. So that will change depending on if I'm working with a 16-year-old versus a 3-month-old, but I'm still going to use the same mindset to help the kids and the families that I'm working with. So this is it's an occupation kind of scatter plot, but a lot of times the kind of running joke in OT is, oh, I already have a job. I don't need occupational therapy. Or kids don't have jobs. Why are you giving them OT? So occupation is by definition something that takes up your time. So these are all different types of occupations. So these are all different areas and ways I can help support people. So play, like that's something that occupies your time. Rest and sleep, education for kids, going to school, work for adults, social participation. Leisure is what play is for adults. So we typically don't play a lot when we're adults, but we engage in leisure, which is things that, occupy our time in a positive, restorative, restful way. And then ADLs and IADLs, they're activities of daily living. And I'm going to explain these a little bit more, but the difference between ADL and IADL is whether it's for yourself or it's for somebody else within your kind of self-care sphere. And I kind of also describe this too like a pie chart. So when a baby is born, the only things they're doing is eating and sleeping. So that's literally all they're doing. They're either awake and they're eating, or they're crying, or they're bonding with their caregiver and they're asleep. I think pooping, I guess, technically is part of the pie chart too. But those three things take up a majority of their time. And then as they get older, you might add in play. And then when they, are kindergarten and older, then you add in school. So your pie chart of how much of those things take up your time changes. So what I do is I look at, okay, what are the main areas this child needs to participate? Are they going to school? Are they in a daycare setting? And then I look at those pieces to kind of help them. So I'm just going to quickly go through these just to give a little bit more information because another thing too is another big thing I've gotten from feedback from families was, oh, I didn't know OT could do that. So I do think that I want to kind of identify a lot of very common things that I treat, but also different things that you might look at or think about with your kids and say, oh, yeah, actually, I would love some help with that. That would be nice. So ADLs are things you do to take care of yourself, and IADLs are things you do to take care of yourself slash others. So very common, daily living skills: eating, bathing, dressing, taking care of yourself, brushing your teeth, brushing your hair, putting on deodorant, painting your nails, clipping your nails, blowing your nose. Like anything you do to take care of your body is an ADL. An IADL are things that require skills, but they typically have a little bit of a more open-ended thing. So picking up your toys when you're done playing with them is a skill. Putting things away, being able to say, hey, can you put these, these shoes in the cubby? Can you put these books on the bookshelf? Being able to organize and use materials. Feeding a pet, being able to take food out of a bin and feed your cat, being able to put water in the bowl for your parakeet. Like those are IADLs. Setting the table, emptying the dishwasher, washing dishes, any sort of simple kind of, I say, household chores typically fall under IADLs. Sweeping, mopping, using a vacuum, replacing towels, doing laundry, those types of things. This one isn't a specific occupation, but I found that this over the years has become a huge area that I've helped a lot of my families with. So I just wanted to highlight this because this is something that you can get specialized OT support for. So feeding, eating, and picky eating. So OTs can help kids with being able to use utensils and feed themselves, even finger feeding. Eating and chewing, being able to figure out how much my mouth can hold, how to eat and chew and manipulate different types of foods. Picky eating challenges, so kids that need expansion, so they only want to eat their preferred things and they're not interested or are not able to try new things. Kids who have food aversions, like, oh, they only want things that are, crunchy and dry. They're not interested in like touching wet foods or messy foods. And emotions surrounding food. I bring out a new food and my child starts to gag and cry. Or, every time we sit at the table, it's a battle to get them to sit and have a meal with us. So it doesn't always have to be just about eating the food. Sometimes it can be the mealtime routine and the emotion surrounding the food. So helping families and kiddos try out different support strategies for feeding, different support strategies for mealtime routines, and also different support strategies for expanding their diet. If a child only eats a few things and mom and dad are like, caregivers, like, I really wish they could eat, pasta because every, Sunday night we have a pasta dinner and I want them to be able to enjoy that with us. Play. So, like I mentioned before, play turns into leisure when we become adults. But the diagnosis, the definition of play is engagement for engagement's sake. So it's when you ask kids like, "Why are you running around and doing? And why are we running around and pretending you're dragons?" They're like, "I don't know, it's fun." So the purpose of play is just to do it, just because it's fun. And play comes naturally to most children. They're naturally inquisitive and interested in trying new things and exploring their world. But for some children, play is not an innate thing and it's not a easy thing for them to do. So teaching children how to play, how to engage in play with others, how to expand play for certain types of activities. I would say in one population in particular with children with autism, play does not come naturally in some situations, and also purposeful play or how to use items the way that they were intended. Sometimes children like to play with certain toys. I've worked with a child that loves to play with Legos but just wants to bang them together. So expanding his play skills of, oh no, we can build a castle with these Legos, or we can stack them up and knock them over. So helping kids expand their ability to play with certain toys or objects or even play in certain games. I've taught kids how to do follow the leader. I've taught children how to take, a movement seeking thing like running around and turn that into tag so they can play with their friends on the playground. Um, but being able to purposely find enjoyment in play is really important. Social participation. So I like that picture of those two little ones. So social participation is pretty straightforward, right? It's being able to socialize with others. But the term socializing can be really open-ended because, social engagement for 3, 4, 5 month year olds is going to be different than socialization for a 16-year-old. So when I talk about socialization or social participation, I break it out into a couple of different things. And like I mentioned, this will change depending on where the child is at in their development and also how old they are. But looking at being able to initiate social interactions. OTs do not specifically work on communication. That would be a speech therapist, but OTs can work on being comfortable being with other kids, trying to walk up and say, "Hey, can I play?" Like, how does that child initiate or begin that social interaction with another kiddo? Maintaining social interaction, engagement, or making friends. I say that sometimes, like, I have kids that say, "Hi, how are you?" And then they're stuck. They're like, "I don't know what else to do. I've said hi. That's it, right?" So, okay, how can we jump into play? What do we do after we've said hi? How can we keep playing with that friend? Oh, okay, you want to be all done playing this game? What can I say to the kids I'm sitting with or do I just get up and walk away? How do I understand my role in a social engagement, pre, during, and then post that, meeting and greeting? Expressing wants, needs, and feelings. So again, OT doesn't specifically work on the communication piece, but being able to be better in touch with themselves to say, like, "Oh, hey, I don't like it when you take my toys," or, "Oh, can you hand me the blue paint? I want to paint, a whale." Being able to ask for things they want, being able to tell their friend, "Oh, I don't like that. Please don't do that." Or, "Hey, I want this." Or, "Oh, let's build, a castle. I want to pretend to be a dragon." And then emotional regulation and intelligence is the ability to understand what their thoughts and feelings are, what angry feels like in their brain and body, what happy feels like for them, and then how they can connect. Oh, this is what I feel like when I'm happy. Oh, that's what somebody else looks like when they're happy. Oh, when I reach out and hit them, oh, they look like they're not happy anymore. Oh, if I reach out and give them a hug, or if I reach out and I pat them gently, oh, they look like they're happy. Okay, I can connect how my actions impact that other person, make that other person feel. And then resolving conflicts, how to, initiate that sorry piece or recognize, oh, I took that kid's toy. Okay, what should I do next? They seem sad. Okay, I should maybe give that back. Um, a lot of times, if socialization is a huge piece, kids typically, like I mentioned, will get speech and OT together because the ability to communicate their, language pragmatics and the skills needed to have higher level communication for social interaction is supported by a speech therapist. But OTs absolutely work on this as well to help kind of maintain those things if verbal expression or verbal communication is not the biggest barrier, and there are other things that can help be supported and worked on. Sleep. So I always think it's funny that sleep is one of the occupations, but it is. It's something we do, as adults. You're recommended to do it at least, around 8 hours a day. Children do it for much longer. So the ability to, like it says, so sleep is a state that our bodies enter daily for set periods of time, and it's really important for development and health. The ability to sleep, close your eyes, slow your brain and body down, lay in bed for long enough to feel sleepy, to know what it feels like to be sleepy, to maintain, it's called sleep hygiene, but like getting into PJs, getting into bed, staying in bed, all of those things around sleep for the routines. Can be a part of OT. Oh, my kid really struggles to, wind down and it takes a really long time. Or my kid goes, 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 and then they crashes. Or my kid doesn't sleep through the night. Those different things that have to do with sleep can absolutely be something that an OT can help support. Again, I think that OTs work really well in collaboration with other professionals in certain things. And like I said, with the social participation and speech, sleep is another one that's really good to collaborate with other medical professionals. Because if your child is having significant disruptions in their sleep, or they are having, say, nightmares, or if they are just really struggling with the kind of restfulness and maintaining that sleep or that deep, sleep cycle, talking to your pediatrician or getting a sleep referral or a sleep specialist for a sleep study can also be helpful for that. Education. So I kind of like these three different, ways to describe education because I think we all have a general understanding of what it is. But education is receiving or giving instruction. So learning about something else. I did like that it says enlightening experience because you can, see by this child's face, I don't think he's particularly loving whatever he's doing. But education, especially for school age children, elementary age children. So, that 3 to 4 preschool age, all the way up until 10 or 11. That is a huge chunk of the kids that I work with. I would say the biggest population I work with is 4 to 9. And so education as one of their occupations is a big piece of school age children's day. They spend, a majority of their day at school or at daycare or at preschool or at a play care or something along those lines. They spend most of their time doing something else outside of their house. And so you can get OT in certain ways, and I'll talk about this a little bit later, but there can be education based or school based OT, academic based OT, and then there can be outpatient or medically based OT. But the ability to be available for instruction, the ability to sit still and pay attention, the ability to complete their worksheets, use their pencil, those things are things that OT can help support, which is why there are services in schools specifically for education. So I wanted to this part a little bit because I feel sometimes like the terminology for this can get a little confusing or can be sometimes challenging to see, but these are all the different types of motor skills. So if you see something that says fine motor, it means anything to do with the small muscles of your fingers or your hands. So think of cutting, coloring, drawing, pasting, any sorts of tabletop arts and crafts, manipulating fasteners, buttons, zippers, snaps, being able to have the strength to open and close doors, open and close containers. Really anything you can think of that would use your fingers or your hands falls under that fine motor umbrella. Gross motor skills are anything that uses the larger muscles of your body. So think your arms, your legs, your core, your trunk. So a lot of gross motor skills are typically bigger body things. So running, jumping, playing any sort of kind of sports, climbing on equipment, really anything that requires the use of your whole body in a bigger, more kind of coordinated effort is a gross motor skill. Visual motor skills are anything that coordinates what I'm seeing with what I'm doing. So the most common visual motor things that we see in OT are, again, some of those tabletop things: cutting, coloring, drawing, being able to complete a hidden picture and find things. So anytime I'm using my eyes in a way other than just seeing, and I'm trying to orient something, understand something, look through something. Um, a lot of kids who struggle with visual motor issues will say, like, "Where's my thing?" Or, "Where are my shoes?" And they're like, "Oh, honey, they're on the bookcase." And they walk up there and they're like, "Nope, I can't see it." And it's like right there. Sometimes the ability to scan and look around and use my eyes to coordinate a movement can be tricky. Um, Ocular motor is slightly different from visual motor because ocular motor is just the ability to move your eyes in a purposeful way. So a great way to explain it is, I see this a lot for kiddos that have trouble moving their eyes to uh, be able to adjust or understand depth. So a child who trips a lot because they can't recognize the changes in, threshold heights, or a child who you throw the ball to them and it kind of bonks them in the chest or will bonk them in the face before they react to it. So anything about using my eyes to perceive what's going on and use them in a way to understand my worlds better can be an ocular motor thing. This is different than acuity. So it's not how clear do I see, it's how can I use my eyes to help me understand what's going on. And then oral, again, this can collaborate a little bit with speech therapy, but oral motor skills are anything that uses your tongue, lips, cheek, and the structures of the inside of your mouth. So a lot of times kids who are working on oral motor skills might be kids that need strengthening. If it has anything to do with eating or feeding, that'll be a piece of it as well. And then sometimes it can be things that are oral sensory based. So I have worked with a lot of kiddos who put, anything they see in their mouth, or kids that chew on their clothing, or are longtime thumb suckers. So sometimes it can be the use of their oral structures in a sensory way as well. All right. So this could be a completely separate presentation on its own, but I think that I would say the past 5 to 8 years, this has gotten a lot of media and kind of like societal attention. So this has become a huge area of treatment for OT, and we are one of the only specialties that specializes in this. But sensory processing is something you'll probably see a lot, or just sensory, and it's the ability to take in, understand, and use this information. So we engage in sensory processing all day long, every day. If you think about how difficult life would be if you couldn't understand the feeling of your clothes on your skin, if you weren't able to use the information of whether something was hot or cold when you were eating something. When you put it in black and white terms like that, it seems pretty obvious the importance of sensory. But when you are a child and you might have difficulty understanding your brain and your body or understanding how those things move, that can be difficult. So, since sensory processing is so all encompassing, it's something we do all day, every day. You're even doing it at lower levels while you're sleeping, which is why if somebody held up a really loud alarm clock next to your head, you would hear it and you would wake up. So it exists the entire time we're alive, basically. Um, it can be something that can be addressed in multiple different areas and in multiple different ways, and it can be different for different kiddos. This is just an eight senses to kind of talk about how sensory processing and our sensory systems have kind of expanded outside of the original five that we're familiar with. So, sight, smell, touch, taste, and hearing are the original ones that we're very familiar with. We learn about in school, and they're the most easily accessible and identifiable because we can use them on command. The ones below, vestibular is your movement sensations and your balance. Proprioceptive is your awareness of your muscles and space and how to use your joints and your limbs and coordinate things. And interoception is your internal sensations. Do I have to go to the bathroom? Am I hungry? Am I tired? Something hurts. I can tell I can tell that my stomach is hurting versus, my foot is cramping. So those ones are a little bit harder to label and identify, especially in children who can't articulate it themselves, because those are things that are happening inside our body and they don't have a tangible way to identify them. But they are incredibly important and they are things that we do need in order to be able to kind of function. So sensory processing difficulties. So sensory processing difficulties, or what's kind of been a coined term of sensory processing disorder, is the ability to or the inability to process sensory information, and the way that it's processed is in a kind of maladaptive or non-functional form. So this little girl right here is getting her hair cut, or it could be a little boy. So this child is getting their hair cut, and the act of getting your hair cut does not hurt, because we all know that getting your hair cut doesn't hurt, because what really hurts is the root. So as long as that hairdresser is not pulling really hard, this child is not actually in pain getting their hair cut. But for them, it could be a very difficult, scary, stressful, or potentially sensory wise aversive experience for them. So if you think about, does it make sense for the child to be perceiving pain while they're getting their hair cut? No. Does it make sense for a kiddo to run and scream away when you say, I need you to clip your nails? No. And is their response to that appropriate? And does it help them? No, it actually is a barrier. It makes it harder for them. If they never get their hair cut, there might not be health ramifications, but it's going to be tricky. They may not want to have super long hair. Um, so that is where we then address a sensory issue. So everybody's different. Everybody likes and dislikes different things. Everybody is annoyed or soothed by different things. So there's no right one way to process our world and to develop ourselves. But when you work with children and they have certain sensory preferences, sensitivities, challenges that are a barrier to their ability to pay attention, engage with their friends, wear clothes that make them comfortable, eat a wider variety of things, understand and listen to conversations. That's when then we in OTs would suggest or recommend supporting or helping a child or helping a family if their child is having sensory processing challenges, because in that way, the way that their brain and their body is interpreting the world is making it harder for them. So these are some examples of some sensory things that I see pretty consistently with the kids that I work with, if they're coming to me for sensory challenges. Sensitivity to self-care, brushing teeth, clipping nails, washing face, putting their head underwater or getting their hair or head wet for showers, haircuts, dental, going to the doctor, going to the dentist, anything that has that kind of like self-care health-based thing, but it's a touch-based thing, can be really hard for those kids. Picky eating and restrictive eating. So kids who, they eat crunchy, carby foods all day long, but they don't have any fresh fruits and vegetables in their diet, or they only eat these 7 things and they're really fearful of trying something else. Kids who have significant meltdowns, tantrums, or behavioral challenges typically have some sort of sensory processing challenge in the mix of that. I always say it's not sensory or behavior, it's always a blend of both. But if you have a child that's having these terrible knockdown, drag out tantrums for a very long period of time and they're really struggling to soothe themselves, or they just cry and cry until they just like, peter out, there might be a way or there might be a piece of sensory in there that's impacting that. And we can see if we can help to support them. Anxiety or significant emotional distress is another one that OT can help with. Coping tools and strategies to help calm their brain and body to feel more comfortable can be a great way that OT can help kind of work on the mental health or those kind of fearful reactions for kids. Attention issues, whether a child does or doesn't have a formal diagnosis of ADD or ADHD, difficulty paying attention has a sensory component to it that can be addressed in some capacity. And then balance, coordination, body awareness issues, kids who never learned to ride a bike, kids who are very clumsy, children who kind of seem like they're lost in the sauce and they're just like bumping into friends, or when they go to play with someone, they're like, I want to play with you. And they put their hands like on the kid's face instead of, keeping their personal distance. And then the last one I'd like to just reiterate, anytime there is a significant restriction to the ability to engage in something that is meaningful for the family, for the child, or is important or necessary for the family, for the child, whether it's health based, safety based, if the child is unable to do something that's really important to them or to their family, if they're younger and they're not able to understand that, and the sensory seems to be a piece of it, it can be something that can ideally, hopefully, be addressed in OT, and we can look at that and help support a family with that. So I've answered this question a little bit, but I kind of wanted to identify, okay, Katie, you've talked about, all these different things that you can help me. Well, how can you help my kid? Like, what can OT actually do? So the way that OT works is that occupational therapists will complete an initial evaluation and then look at the child from all different angles. They'll look at them from social, emotional, sensory, developmental, fine motor, gross motor. They'll do the whole kind of stem to stern look at that child and assess if any of those areas of occupation are delayed, impacted. Parents typically come to me with some initial specific concerns that are really important to them. So looking at how does that parental concern work its way into the puzzle of the child I'm seeing. And then we provide therapy. So therapy is available for children of any age. If you have a child and you're looking to kind of attend a pediatric clinic, they typically work with children from birth to 21. So if your child is within that age gap, they should be an available population for a therapy clinic. Therapy sessions are different depending on which clinic you go to, and especially in school, they're very different depending on length. But they're usually anywhere from 30 minutes to an hour, and sessions can be anywhere from 1 to 3 times a week. Again, this can change and be very different. So frequency and duration of therapy is based on the recommendations from the eval. But just to kind of give you an idea of what you might see or might kind of come across if you are interested in pursuing therapy for your child. So I wanted to take a quick second to kind of identify the differences between school and outpatient OT because there are some pretty concrete differences. And you might be saying, "Oh, well, I want my kid to get, OT outside," or "Oh, I didn't know they can get it in school." So I just wanted to kind of quickly identify this. So school-based OT is really focused on the success and engagement in school. If you look at some of the language in the legal documentations for school-based services, it says academically relevant or required to participate in the academic realm. So it's really focused on their day at school. And therapy is given for OTs specifically, therapy is given through an IEP. And if they have a 504 or other kind of consultation plan, they usually get consult services or something supportive. But direct one-to-one therapy is given through an IEP. A lot of the common areas that you will focus on if you're doing school-based OT is those fine motor and visual motor skills, handwriting, cutting, coloring, drawing, pre-writing skills, manipulating materials, having access to things, a lot of those hand-based, hand-eye coordination-based tasks. Sensory is a big piece of school, whether it is sensory diets to improve their ability to tolerate school or sensory diets to help them organize and calm down. Emotional regulation and behavioral challenges are one that is addressed in school by school-based OTs. And then anything having to do with those ADLs, those self-care things, toileting, managing their clothes before and after toileting, eating, getting dressed, manipulating fasteners, packing and unpacking their lunchbox, being able to carry their backpack, those kinds of like management of those materials is a school-based thing. So the difference in OT for outpatient OT is that they use a medical model. So a lot of insurance companies um, have a clause in their kind of plan of medically necessary. So the evaluation looks at it and then says, okay, Johnny needs help in these areas. Do they require medical based OT, outpatient OT, and intervention to help with those things? And that's what our evaluations identify and support, saying, yes, we do think that the child would need these types of things. So the common areas that we're able to focus on is, like, I kind of say almost everything, because outpatient OT, as long as we're able to identify and recognize that it's a necessary need and that there is a functional deficit, outpatient OT can work on almost anything. So we can do all of the things that school-based OT can do and more. We can dig a little deeper into emotional regulation. We can do more sensory than school can because we have a wider base. Because what we're looking at is not just how does it impact their day, we're looking at how does it impact them as an individual. So I do think that outpatient OT is fabulous, and I appreciate having the ability to work in this realm because it gives me more flexibility. But I do think that school OT is incredibly beneficial because outpatient OT happens in the clinic outside of school. Having the intervention and support and the skills from a school-based OT in school is also incredibly important if that's an area that these things are happening. If you remember the occupations we talked about, education is one of them. So having somebody to help support that daily occupation for kids is important. So if you're listening and you're like, okay, I want to get school-based OT for my kid, how do I get this started? So for school-based OT, you would contact the admin. This could be the principal. It could be your contact admin at school. Sometimes just talking to your teacher can be a great way to get the ball rolling. And you say, I want to request an OT evaluation. Schools, whether your child qualifies for OT is an individual case by case basis, but all children and all families who are interested in having OT get an evaluation. Your child can always have an evaluation. Whether or not they qualify is based on the results of the evaluation and the PPT team, but your child can always have an evaluation. So once you request the evaluation, they will then have a PPT, which stands for a planning and placement team, and they will meet to discuss the results of the evaluation. If you're seeking services other than OT, the other professionals will be there to go over whether it's special education evaluations, PT, speech, psych or counseling support, really kind of whatever support you're looking for your child. That meeting will then discuss the results of those evaluations and whether they qualify for services. If your child qualifies for direct one-to-one services for OT, it has to be under an IEP, meaning your child has to be receiving special education services in order to be able to get OT direct one-to-one. If you have a 504 or an SRBI or another style of support, you can get consult services through OT. We can create sensory diets, we can meet with teachers, we can observe, we can modify things, we can provide adaptive equipment, we can do lots of other things. But since OT is considered a related service in Connecticut, we cannot do direct one-to-one therapy unless the child has an IEP. For outpatient clinic, if you are interested in services, you could call us if you're interested in getting services from us, or you can, go on to, Google's a great resource and just Google pediatric occupational therapy, find the clinic that you're interested in. You call them and you say, I'd like to set my child up for an OT eval. Every clinic will have different policies, but they're all pretty standard. They'll have you fill out intake paperwork so they can get your information and your insurance information. They will then contact the insurance company to confirm that they're in network and that what you're asking for qualifies as part of your benefits package. You're also strongly recommended to call your member services line and say, hey, I'm interested in getting my child OT. Is that covered? Do I have benefits? What does that look like? Just so you have everything on the table, whether you have a visit limit, whether there's a deductible, just so that everything is available and you understand how going through insurance-based OT can work. And then most insurances, again, similar to school, where we're a related service, you'll need to get a referral from your pediatrician or your doctor. And that's pretty easy. You don't typically have to go to get an appointment. You can call and say, hey, I'm interested in these. Or at your most recent pediatrician visit, you can say, I want to request an OT evaluation. Can you please write me a referral? And then we will schedule the evaluation. Your child will meet with their OT. They'll do the evaluation, and then you'll get a written report of the findings from the evaluation. Once you receive that report, you can then go over the findings with your therapist, and then they can schedule services with the duration and frequency that makes sense for what your child is looking for. Um, I would say, if you're looking at like, okay, so I'm going to get services, like how long is this going to take? That's another very common question I get in schools. If your child qualifies for an IEP or a 504, they go are on a yearly basis. So your child will have services for at least a year until they have their annual meeting. And at that annual meeting, they'll then go over and see, okay, what are what's the progress been made with the goals? Do we need to write new goals? Like, what does that look like? So you'll get updates way sooner than just a year, but that's typically around the decision point of whether the child will continue to qualify for services around that 1 year mark. In outpatient OT, it's much more flexible in terms of how long you want your child to come for services and how long you're interested in having services supported for your child, depending on the areas of need. So I would say therapy is usually anywhere between 6 months to 2 years. Children who come for 2 years typically come for a much broader spectrum of deficits, so it's not just like if I had a kid coming just for some tactile sensory issues for, brushing their teeth, they're not coming for 2 years. This is a child the children I've seen for multiple years are kids that have gross motor, fine motor, sensory, developmental concerns, like there's a bigger bubble. But I think having an honest conversation with your OT is the best way of saying, hey, I'm really interested in knowing how long OT will last. Like, what do you think? It's not a cut and dry answer, but I do think that your therapist can give you a general ballpark based on the amount of concerns you have for your child and your interest in it. So, any questions? So, what I'm going to do now is I'm going to pull this off of the and stop sharing my screen so that if anybody is interested in asking any questions off screen, I can take those questions now.
Thank you so much, Katie. At this time, we will actually stop the recording so that way we can give privacy to families. Thank you so much.